little bit about nurse mid the role of the certified nurse midwife and the role of the WHNP. So our presentation this evening is about the way that those roles really empower nurses to advance their professions and provide guiding hands to care for the people that we serve. So I am Eileen Thrower. I am the department chair for midwifery and women's health at Frontier. And I am delighted to be with you tonight. And I'm going to let Dr. Eva Freed introduce herself.
Hi, I'm Eva Freed. I am the clinical director for midwifery and women's health at Frontier. And I'm actually representing Frontier in our swag sweatshirt, but I realize most of it's not showing and it looks like I'm just sitting here in my pajamas. So I wanted to show you, we have super cute merch and I'm representing it tonight. So happy to be here with you.
Thank you, Eva. The roles of the nurse midwife and the WHMP are really varied. And I think a lot of us sort of tend to pigeonhole our ideas around what we think those roles might look like. But I hope that tonight we're able to kind of expand your role of what you may think those two professions encompass, because as you can see from this picture, it's a lot more than caring for someone who during childbearing years or during labor and birth. It also encompasses lots of other things. And we're going to talk about that as we move through our presentation tonight. We are going to discuss the roles, the experiences, some of the challenges of these two professions. And we're also going to talk about the path that leads to advancing from the role of a nurse to the role of an advanced practice nurse, and a little bit about what to expect once you get there. So let me just start off by talking a little bit about advanced practice registered nurses. So for most of us in most states in this country, we would practice as a nurse midwife or a women's health nurse practitioner under the license of an advanced practice registered nurse. There are some exceptions to that, and there are variations on that across the country, depending on the legislation in any particular state. But in general, the majority of midwives and WHMPs practice as advanced practice registered nurse. That includes a variety of other nurse practitioners, as you probably know, family nurse practitioners, pediatric, neonatal, those types of things. Certified nurse midwives, our CRNA peers, and our clinical nurse specialist peers. So all of those roles are included under this larger umbrella of the advanced practice registered nurse. At Frontier, just for the sake of being thorough, we offer both the nurse midwifery and the WHMP programs, but also we offer family nurse practitioner and psych mental health nurse practitioner programs. So let's talk a little bit more about the role of these two groups, the excuse me, I didn't mean to advance my slide on myself, the role of the nurse midwife and the role of the WHMP. There is a lot of overlap in the two of the roles. They both care for people across the lifespan. Anyone who identifies as a woman or who was assigned female at birth. So those roles have both expanded to be inclusive of all genders, all biological sexes and gender identities. Obviously, this is may or may not be already pretty apparent, but both roles, because of the fact that they're rooted in the profession of nursing, are really focused on things like health promotion, disease prevention, education around health. But we're going to talk a lot more about what that really looks like. But there is a lot of overlap in the two roles. They each have their own unique professional organization. The American College of Nurse Midwives is the professional organization that specifically represents nurse midwives and certified midwives in this country. Certified midwives are a group of midwives who are educated and certified with the same certifying board exam that's administered by the American Midwifery Certification Board, but they do not first become nurses. So that's the American College of Nurse Midwives. And then the NPWH is the organization that is more specific to WHMPs, and that is the National Organization of Nurse Practitioners in Women's Health. I will say that both of these professional organizations are open to nurse midwives and WHMPs. Both of them have members that represent both professions, and really, again, a lot of overlap in both roles and in both professional organizations. Other ways that the two roles of the nurse midwife and the women's health nurse practitioner are very similar continue, as they are both really considered and defined as primary healthcare providers across the lifespan. So both of them, both WHMPs and nurse midwives, perform physical exams. They provide well person care. Both include prescriptive privileges in most and almost all states these days, included prescribing medications, obviously, that include family planning kind of medications, but lots of other things as well. Order and laboratory and diagnostics tests, provide lots of care, focusing on gynecological care, obviously prenatal care, but also primary health care. And as I kind of already mentioned, healthcare and education across to people of all ages across the lifespan. So some of the differences really lie in a couple of different areas. Obviously, both are providing care for people as they're in that reproductive era of their lifespan, but midwives obviously attend labor and birth, and WHMPs do not. But in addition to that, midwives are also certified to care for newborns up to 28 days of age. That becomes really important for midwives that are working in community birth, so at a birth center or at a home birth practice. That newborn care really does in a very real way fall to the midwife in those settings. Also, midwives care for partners of their patients, but only very specifically as expedited treatment of sexually transmitted infections. If you contrast that to the WHMP, while they're not caring for people during labor and birth, their focus is a little more expanded when you're looking at the fact that they do provide full sexual and reproductive care of folks that are identifying as men. They're also providing there's a stronger emphasis on gender-affirming hormonal care. And I think in a lot of ways, there's a little bit more of an in-depth interest in caring for menopausal folks, not just the sexual and reproductive care of menopausal people, but people across all of the spectrum of primary care needs for menopausal people. There's a strong emphasis that the MPWH has identified as part of the role of the WHMP in that area. And I think in general tend to do a little bit more of the high-risk complex care of both obstetrical and gynecological type care. So that's kind of on the surface of it, what you would find if you did a quick Google search about what the difference in the roles are. But for a few minutes, I'd like to talk about what that really translates to for somebody that works as an APRN, as a nurse midwife or a WHNP. It does have a different sort of work-life flow, I think, in a lot of ways, because the midwife is attending births. That then necessarily includes some type of on-call schedule. And obviously, we all know that those babies come when they're ready to come, including holidays and weekends. So it's certainly not something that is limited to office hours Monday through Friday. Although I will say that there is a good bit of time that midwives spend in those office hours Monday through Friday. And depending on the setting, sometimes the midwife hours are fairly structured in a way that you have a fairly predictable schedule, even though it does include some of those overnights and holidays and weekends. Midwives practice in a variety of settings. Birth centers are typically run by midwives. So anytime you have a birth center, you probably would be not surprised to find midwives there. Certainly midwives are also working in home birth practices. But I will say that the majority of nurse midwives in this country, greater than 95% of nurse midwives, are working in settings that are hospital based. So they're not spending all their time in the hospital. They're spending a lot of their time at the adjacent office, the outpatient office or clinic. But most midwives do their births in a hospital setting. So women's health nurse practitioners are more focused on the outpatient office or clinic setting. They do have a typically more predictable schedule that does more often reflect that sort of Monday through Friday work week. Although I will say that WHMP, the role of the WHMP is rapidly expanding, and more we're seeing WHMPs working at inpatient settings. A couple of examples of that would be, for instance, in a triage unit in a labor and birth setting within a hospital, and also potentially on the postpartum setting, doing postpartum rounds and those kinds of things. So I think that is a place that is opening up more to our WHMP peers, is in that inpatient setting in some of those types of situations. An exciting thing about the role of APRNs, both nurse midwives and nurse practitioners in general, is that it is really a very rapidly expanding profession right now. There's about a 40% growth predicted from the year 2023 to the year 2033. So it is a job that I think our graduates can feel fairly confident in finding employment after they have completed the program. As I already kind of mentioned, both for nurse midwives and for WHMPs, they're just ever expanding and growing roles and opportunities, places that you can put these roles into play. A few statistics for our WHMP providers in the country, our WHMP clinicians. There are approaching about 13,000 licensed women's health nurse practitioners in the US. So which really represents about 3% of all the nurse practitioners in the country, although I do think it's a growing and expanding role. More than 40% of full-time nurse practitioners now are doing some of their hours at a hospital in some capacity, one way or the other. And nurse practitioners hold prescriptive privileges, including prescription of controlled substances in all 50 states at this point. So here are some statistics about some numbers. You can see the sort of the median salary as of the most recent data that we have available shows that the salary for a WHMP is a little over $100,000. I will say that most nurse practitioners are going to be seeing more than 3 patients per hour. So I think that is a consideration for folks as they're thinking about whether or not this would be a role. It's a busy role where there are lots of patients on a schedule on an average day. Nurse practitioners in average have about 10 or 11 years of experience. And also, as you can see, are about 49 years of age. So that kind of speaks to the need, the ever-growing need for more nurses to consider this role as folks age out of practice. So this is the percentage of where WHMPs find themselves working in after they're done with school. The vast majority, as you can see, end up in direct patient care, with a smaller amount doing things like teaching, management or administration, and research. But then there's also this really important small segment of the WHMP population that is working in health policy and advocacy. And so I appreciate those folks that are doing that. And then about 7% of all licensed WHMPs are currently retired. So I'm going to turn it over to Dr. Freed to maybe discuss a little bit more about the midwifery profession.
Thank you so much. And I'm going to need you to still advance the slides for me. And Brittany or Quincy, maybe one of you can jump in. I can't remember, what is the opportunity for folks to ask questions? I see we don't have the chat open.
They should be able to ask questions verbally at the end if you would like.
Okay, we can do that. That's fine. Okay, that sounds good. Thank you. So there are several pathways to midwifery, and Dr. Thrower really spoke to the main one. If you're members of A1, you're nurses, and so most of you are going to be looking at the certified nurse midwife path. But just like there's so many pathways to nursing, there are multiple pathways to midwifery. So if you're curious about that or find that a little bit confusing, you're welcome to take a screenshot here and see that, like Dr. Thrower said, there is a role called the CM, the certified midwife, which is folks that take the same certification exam as certified nurse midwives, but they don't become nurses first. And there are, I think, about 100 of those folks with that certification practicing in the US. And then there's also certified professional midwives, traditional midwives, and community midwives. And then, of course, people use some other descriptors to describe what they do. Next slide, please. And then there are, interestingly, about the same number of nurse midwives as there are of WHNPs. So, and we're both small relative to family nurse practitioners and other kinds of advanced practice roles. So again, just to reiterate what Dr. Thrower said, the organization Nurse Practitioners in Women's Health and the organization American College of Nurse Midwives both have membership from both specialty areas because we have a lot of overlap, particularly in terms of the approach to care, the normalcy of reproductive function, the normalcy of life changes, the normalcy of birth, puberty, menopause. So really similar kind of philosophical leanings. And then, yes, I was trying to recall from memory how many certified midwives there are. So 130 as of 2021. And then just under 3,000 certified professional midwives. And you can see that the vast majority of midwife attended births are attended by CNMs, just because that's who the majority of midwives are. Next slide, please. So nurse midwives tend to have a bit of a higher salary than nurse practitioners, although I will say I live in the Midwest in a very low cost of living area, possibly one of the lowest cost of living areas. And I do see women's health NPs starting at about 110 where I am. So I think the pay scale that we saw was on the lower end. Nurse midwives do tend to start at a higher salary, but they often work 50 to 60 hours a week, or at least have 50 to 60 hours a week on their schedule, even if some of it is call time, and work more weekends and holidays. And so it's never too, even before you think about going to graduate school, it's never too early to think about the fact that when you're thinking about a place of employment, there's a lot more to it than money. So hours, vacation time, demand on your life, lots of other things to think about than the salary itself. And then also I would say that probably these folks that are listed as working colleges, universities, and professional schools are in a teaching capacity rather than a clinical capacity. So that's probably not what you all would be thinking about at this stage in your careers. So this is totally off the top of my head, but from having been working with students going out into practice for about 12 years, I see a lot of students starting in the 130 neighborhood on average as nurse midwives. And so you might be thinking, oh, I work as a travel nurse and I already work, evenings and weekends, and that's not that big of a salary differential. And you are correct. The salary differential is usually not a big motivator for students to transition from an RN role to a provider role. So it's definitely something to think about. It's more of a lifestyle and satisfaction and, where it really works for you in terms of, what feels satisfying for you in the workplace. Next slide, please. Thank you. So the midwifery model of care is very well articulated. And, oh, yay, I'm seeing things in the chat. Okay, I'm going to look at the chat in just a moment. The midwifery model of care is very well articulated, but I will say that there's quite a bit of overlap. Being involved in both professional organizations, there's quite a bit of overlap in terms of midwifery model of care and the women's health NP model. So you can see some of the statistics here. Of course, the question is always, do we take care of lower risk people to begin with? Yes. So you got to dig into the data on, what part of this is because we take care of lower risk people and what part of this is because of the time that we spend developing trust and, allowing the body's natural processes to work. So some of these are attributable to one and, certainly some to the other. But you'll see that we also have high levels of patient satisfaction. And I would definitely argue, having investigated the data myself, that, for example, something like the lower C-section rate is going to be related to the time that we spend at the bedside and the time that we spend with people ahead of the birth experience. I'm going to just pause. Now I see that the chat is active. It's just that no one was in it before. So thanks so much for that, Brittany. Okay, yeah, so Delaney, if that's your first name, you're welcome to save them for the end, but also Dr. Thrower and I are very accustomed to responding to what folks are interested in real time. So up to you how you want to handle that. So yes, options at Frontier are, we do expect everyone to be an RN before coming into the program. Not all programs are like that, but ours is. It jumps off from that point. And in terms of the things that we're talking about tonight, we offer the certified nurse midwife or the women's health nurse practitioner. We also offer family nurse practitioner and psych mental health nurse practitioner. If you're thinking about branching out a little bit, I'm sure that in your nursing roles, you've probably thought of all of those things because they're all areas where we need more care providers. And a lot of folks do their first advanced practice certification at Frontier and then come back for one or more additional ones as a postgraduate certificate student. So we make that pretty seamless. Next slide, please. Thank you. Oh, yeah. So interestingly, you can come into our program with a BSN or an RN plus a bachelor's in something else. So for example, my bachelor's was in gender studies. So then I did an RN and I didn't go to Frontier, but there are different ways that you can put together the bachelor's degree and the RN. So again, it can be as a BSN or it can be a bachelor's in something else and an RN, and that can take you right into one of our graduate programs. So I'm going to say something else. I was waiting to see if there was a slide about this, and maybe there is next, but I'll just say it now anyway. You'll see that our programs are not BSN to DNP. Our programs graduate at the MSN level, at the master's level. So there is certainly an option to then follow that with a DNP, and it's a fairly seamless option. But the evidence doesn't really demonstrate that care outcomes are better when folks have a DNP, and we're not interested in putting up artificial barriers to getting more people out into the profession. So we offer the DNP, and we're certainly happy to speak to, why would you choose that or why would you not choose that? And right now, we don't have great evidence to say that patient outcomes are improved with the DNP. And so it certainly costs more money and takes more time to get from the RN to the DNP. So that's why right now we're committed to graduating students at the master's level, but we also do offer the DNP for folks who want that level of achievement or who are seeking a leadership or teaching position at some point in their career. And I actually don't remember if there's more slides after this. Oh yes, this slide that I think about like every single day when I wake up in the morning and I'm like, this is going to be me with my little ponytail riding to the finish line. And then instead I ride on rocks and bridges and water and thunderclouds. And so we know that the journey is not necessarily linear, and Frontier is really, really committed to supporting students through that journey. We also know that at the stage of life when folks go to graduate school, you're often caring for family members, whether they're children or aging family members, and you're trying to earn a living and you're active in your community and you're looked to as a leader in your nursing workplace. And there's just a lot going on, and we have a ton of flexibility and structures in place to help facilitate your success in the context of all of that life going on around you. I love this question that just popped into the chat, and we will definitely respond to that. Thank you. But just to finish that thought that I was having is that when you're at Frontier, we admit a large cohort every term to both programs, WHNP and midwifery. And so it's quite likely that even though it's a distance program, there could be somebody that is in your community. And also we have mechanisms to foster relationships with folks who might not be in your community by getting to know them within your courses. So even though we're a distance program, it's definitely not like, you log in and do your thing and you feel like you don't know the faculty and you don't know the other students. We're very invested in scaffolding your learning experience with a community. And so we have structures in place to establish that community for you, both before, during, and definitely after school for the remainder of your career. Are there any additional slides? Okay, and you are welcome to read this, but highlights are that we're invested in serving rural and underserved communities, which is one of the reasons that we became a distance education school in the first place, was so that folks would stay in their home communities and serve their home communities instead of congregating in major metropolitan areas where graduate schools tend to be located. And we've got a long history of that, and we publish very exciting newsletters and blog posts and social media posts on a regular basis that just absolutely blow my mind about people learning at Frontier and returning to their home communities and starting businesses and joining practices and things that I just think take an incredible amount of guts and entrepreneurship, and it's very bold to become a healthcare provider and an entrepreneur all at once. You certainly don't have to become an entrepreneur, but we give you the skills to do so and to really return and be of service in your community and be a leader. And so we're cutting off the apostrophe T. I love an errant apostrophe. Bye-bye. So yes, you can do it. And again, we're there to support you. We don't let you disappear. So anytime, we can see that you're struggling on an assignment or an exam, we actually reach out and follow up with you. So even though you're online, you're not invisible to us. We do come after you. So we only admit students that have demonstrated that they can be successful in the program. So once you're admitted, we're invested in your success. And we come find you if you're not doing what we think you need to be doing. So it's not a place where you can just come and disappear, which is great because you're investing a lot of time and energy and money in becoming a provider, and we want to make that same investment in you. All right, so questions. I will take this first one and then I'll come up for air and turn it back over to Dr. Thrower. So this is a question I respond to all the time. We have a piece of our program called Frontier Bound, which is the term right before your enrollment starts at Frontier. You come to campus for about 2.5 days. And we have this, again, sort of intensive scaffolding to help you develop community and feel like you really are part of the program before you go home and engage in about a year of didactic coursework from your home community. And I'm very, very often talking with students about getting both WHNP and CNM. I happen to have both, and I will just share a little crumb of my own story. I only became a nurse to become a nurse midwife. And then while I was in graduate school to become a nurse midwife, 4 of my 6 children were born. And I lived in a community that was not very midwifery friendly. I still live in that same community. And as I had more kids and got further along in school, I was like, what am I doing? I have all these small people that I am responsible for, and this is a really hostile environment for midwives. And that's, not all environments are hostile to midwives now, but it would have been the job market was not something that would have fed my soul. And I didn't want to take time away from small children for something that wasn't going to feed my soul. And I was like, you know what? I really love GYN. I really love the time that I can establish trust with folks in the office. I still get to do prenatal and postpartum care, and it might not be 12 or 24 hours that I'm with a patient, but there's the repetition from year to year, from visit to visit of caring for somebody. And I chose to graduate as a WHNP, even though I'm pretty sure when I enrolled in that program, I didn't even know what a WHNP was. I started and became a nurse just to become a midwife. And had a very satisfying career as a WHNP for about 11 years. And then I started teaching in a dual program that offered the WHNP and nurse midwife together. And I wanted to be active in some policy work for which it made more sense for me to be a nurse midwife. So it wasn't so much that I wanted to attend births, it was more of my service and scholarship that led me to wanting to become a nurse midwife. And so after I did my doctorate, I actually went to Frontier. That was my first time going to Frontier. And I did the postgraduate certificate program in nurse midwifery. And so that's just a tiny bit of my own story. What I will say is it's becoming less and less common to be able to do the dual program, especially in a program that ends at the master's level rather than at the doctoral level, because state boards of nursing are requiring independent, not independent, like you have to function independently, but hours in clinical that are dedicated to only one track or the other. So even though there is arguably tremendous role overlap between the women's health NP and the nurse midwife, you actually, to satisfy a lot of state boards of nursing, have to complete entirely separate sets of clinical hours. And so it just becomes an enormous number of clinical hours. It becomes very daunting and expensive. Um, so I think that it's difficult to justify getting both. So we spend a lot of time talking with students and potential students one-on-one about what your ultimate goals are. So you can do almost everything that a WHNP can do, you can do as a nurse midwife. And I'm trying to think of how to make the flip side of that. As a WHNP, there are some things you can do that a nurse midwife is not trained to do. And you also don't attend birth. So the lifestyle tends to be different, as Dr. Thrower was saying before. Right now, at this moment in time, the things that a women's health nurse practitioner does that a midwife does not do, just to reiterate what Dr. Thrower said, is gender affirming hormone care and care of folks who identify as male for sexual and reproductive health care. Certainly, there are nurse midwives who do those things in some states, but it's very difficult because state statute dictates some of what you can do in a certain role. So it's not just what your professional organization endorses and what you learn in school, but also what state statute says that you can do. So if you're thinking that you know what you want to do long-term in your career, you might want to investigate that in your state and think about the role that will work best for you. And I'm probably just totally overloaded you with info. So I will come up for air and see if Dr. Thrower wants to add anything or if other folks want to post in the chat.
Yeah, the one thing that I would add is I think let me take the second part of this question about thoughts on F&P with either of those. Honestly, I think that adding the F&P to either the role of the nurse midwife or the WHMP, it has a lot of added value because then it allows you to care for the whole family. And that's something that I see in particular for people that are practicing in rural areas where they may have started off because of a real passion for caring for women, but then realize, wow, that I'm really not able to care for the whole community because I really would like to be able to see the whole family. So I think that has a lot of added value. And this wasn't part of the question, but I'm going to throw it out there also, is that I think the combination of WHMP and psych mental health nurse practitioner or nurse midwife and psych mental health nurse practitioner just gives such a uniquely well-positioned approach to caring, to helping address the perinatal mental health crisis that we have in this country, in addition to the broader mental health crisis that we have. And I do believe it really is um, a just uniquely well qualified position to be in to help address that situation. So honestly, I think doing things like adding the FMP or the psych mental health MP probably are more meaningful in a lot of ways, if that makes sense.
Yeah,
Um,
hit us with more questions. I'm glad
yeah.
you turned on
What
your
do you
camera. It's great to see you.
Hi, I didn't want to scare anybody with the audio first. My name is Cameron. I live here in Texas, so hence the y'alls and the ma'ams, everything. So
I'm right there with you.
okay, awesome.
Yeah, we're in Kentucky. We talk about alls of y'alls.
Okay, awesome. Well, I didn't want to overstep on anybody else's questions. I wasn't sure. It shows that there's only 5 people total in here. So, but if you'll allow me, I worked in labor delivery for a little bit. I currently work at a high-risk pregnancy clinic under WH&Ps. We pair with CNMs and OBs to basically transfer our patients out at the 34, 35-week time frame. I also work full-time as a rescue paramedic at Woodlands Fire Department. So I'm trying to transition, if that makes any sense, going from full-time firefighting. I'll be retiring, I say shortly, but I still have about 8 years to go. And I dived into RN a few years ago. I did end-of-life care for 15 plus years, about 8 of it overseas in Israel and Africa. And I really love the beginning of life care, which is why I've invested in L&D and women's services. What I'm doing right now is wrapping up my bachelor's program, and I'm looking into the CNM, WHP, FNP. Any of those three, and I'm honestly just lost as far as where I should go and what I should do. I've heard lots of mixed information as far as job opportunities and what's available and where things are trending to. The folks that I work under right now have been in WHP for quite a few years. My direct supervisor has been doing it for 33 years. The one above her for about 40 years. And they tell me, hey, try to find the new and updated information as far as what's happening. Because they're not really finger on the pulse as far as what current programs are being offered, where things are going. Y'all mentioned earlier about a lot of WHPs working in hospitals, and they said at the time they started, that really wasn't even a thing. And so I'm honestly just
Exactly.
as far as kind of where to go and what to do, like at the past the bachelor's level.
Well, I think a lot of that, Cameron, is going to be dependent upon what your real passion, where your focus is. If I could make a case for the idea of just doing the F&P, because
Yes, ma'am.
that also allows you to do women's healthcare. And in fact, there are a lot of family nurse practitioners that have spent their entire career focusing more narrowly on women's health. The difference between the F&P and the WHMP, of course, the F&P cares for the whole family. You've got that information about pediatrics and a lot more of the geriatric part of it. And so by necessity, then your understanding or the depth of knowledge that you're getting about women's healthcare is much narrower. So that's really the thing about the WHMP is it gives you such a more in-depth understanding of women's healthcare. So if you're thinking of F&P versus WHMP, those are things to think about. And then the big question is whether or not you want to try to do births. That would then this leads you straight to being a nurse midwife, right? Whether or
Yes, ma'am.
not you combine. But I will say this, if I was going to combine nurse midwifery with something, as I said before, it would be the FNP, because then not only can you can care for the whole family, including those folks that during the time that they're giving birth. So, that's a very comprehensive qualification.
I would agree with that. If you want to do two things, and we actually have at least one person on faculty that I can think of who did both and lived in the same rural area for about 30 years and
Okay.
was really like, for lack of better terminology, like an old-fashioned town doctor, like knew everybody from being the family nurse practitioner and the nurse midwife. This is total presumption on my part, but given that I think you said you're an EMT and a firefighter, it's hard for me to imagine you not wanting the thrill of the births and the acuity.
I
Um,
loved my time in L&D.
yeah,
I worked at a really great hospital. We had
yeah.
a lot of high risk patients, code maroons almost every week, and
Mhm.
we stayed very busy with that. I left due to the 13-hour shifts a night, on
Yeah.
top of 60 hours a week I work on the fire department, and then I got very lucky getting into the clinic that I have now due to the connections that I made. I worked with a
Mhm.
midwife at that hospital in L&D. And she suggested I get more time at the clinic side in order to learn women's health across a broader spectrum, to bring that tool for the toolbox and arsenal later on if I decided to be a CNM. But yes, ma'am, I would absolutely love to get back into delivery. Like I love doing the shadowing. I shadow under an OB occasionally, and I love doing
Mhm.
delivery. So that's the ultimate goal. And then
Yeah.
of course F&P, like how you are speaking of, would give me, forgive the terminology, more flexibility, more I would
Mhm.
say marketability, but I think that would be a little bit better for me, as far as what I'm trying to accomplish over the next, until I retire, is knock that schooling out, work on that clinicals experience, learn about what all I can bring to my community. So yes, ma'am, I think F&P CNIM is where I'm leaning towards. And it's kind of hard navigating as far as what schools are available and what's, what I can do here in Texas and what I can do. Frontier, when I saw that was being presented, y'all were one of my, I was going to link up with y'all probably at the end of the year to try to figure out the exact same questions I'm asking now. Absolutely.
Well, and I can also give you the contact information for their program director for our family nurse practitioner program. I think that might be a great place for you to have a conversation as well. But, the thing about the F&P role is, well, let me back up. As Eva was kind of alluding to, many of us in the midwifery field, we have a little bit of that adrenaline junkie part of us, or we might not be there, right? Although I will say that more and more FMPs are working in much more acute settings, so it certainly is a place where you might tap into that a little bit as well. But I do think it comes down to really a broad question about what your real goals are, how you think you, can make them, what contribution you're trying to make in your community. If you're trying to have the broadest impact on the most people, F&P is obviously much broader. Um, so I think it's just that's a lot of that's going to come down to really where your passion lies. It's always been sort of my opinion that we're better clinicians when we are doing something we're passionate about, so.
Yes, ma'am. Understood. The struggle I think I'm going to run into, and let me know if I'm overstepping on anybody or if y'all need to go or wrap up, but
Oh, we're good.
y'all talked about schedule. So the three CNMs that I currently shadow under work with, I'm actually working on the fire department with the husband of one. So I talk to her almost weekly, and she says there's no way I can stay on the fire department at the same time of being a CNM with that schedule. So what I had come up with the ladies that I work with right now, the CNMs, WHMPs, and OBs, is get CNM but operate almost as a WHMP in the clinic setting. How do y'all feel about that? So that way I can still, I do about 5% pediatric, but the other 95% is obviously pregnancy care, antepartum, however you want to do it, and a little bit of postpartum. So do y'all think that's an option? Get CNM, FNP, and then work in the clinic setting until I can for sure go back to that crazy lifestyle of, delivering at 2:00 in the morning and doing that kind of stuff? Do y'all
Yeah,
think?
it gives you a lot of options. The only thing, and I don't know Texas, so if you do, Dr. Thrower, jump in. But in some states, well, it'll help that you have if you choose to do both and you have the FMP. In some states, if you have the CNM, you're almost stuck staying in a role that includes birth, even when you get, older and don't want to do that anymore. Because either the liability insurance stays prohibitively expensive, even if you're not attending births, or the sort of culture in that state is to not really understand that nurse midwives have all those office skills. So that's something else to explore. And it sounds like you're doing the right thing by talking to folks in the profession. The other thing you can do is look at like the Texas affiliate of the American College of Nurse Midwives. I know they have a big affiliate. You can find them probably just on Facebook and ask folks like, hey, what are you doing? And like, what's your career trajectory and what options would I have in this role? And I only say that versus like a nurse practitioner organization because I'm more familiar with it. But I'm sure there's also like a chapter of the American Association of Advanced Practice Nurses, where you'd find a lot of FNPs who would also be able to speak to their experience.
Okay, no, I definitely appreciate that advice. Thank you, ma'am. Thank you.
Yeah, and I agree. I think it is probably really important for you to, I mean, if you're going to stay in Texas, and I think it's important to talk to folks that live there and try to see if you can discern that. There's a lot of nuances to it. I myself, I'm a nurse midwife. I'm not a WHNP, but there were times in my life where it just didn't work for me to be on call. And so I did work in the office only. So more like in that role of the WHNP. So I know it's done. It wasn't hard for me, but I'm in Georgia, so it wasn't. And it is really interesting how the community setting impacts that, and your ability to get a job. So
Yes,
I will say that is one thing that I know midwives run into sometimes, is that if they're at a point in their lives where they don't want to do birth, they can occasionally have issues with that. So I think I would talk to folks in your community about that.
yes, ma'am. No, definitely. That's something that they've already brought up. The ladies that I've worked with in L&D is
Yeah, I agree with them. It's not going to combine with what you're currently doing, unless you just don't want to ever sleep again, which I think I would recommend.
Yes, ma'am. Yes, ma'am. Yeah. One of the ladies, I believe she's in her late 60s, and that's what she says all the time is, like, hey, if you're going to do this, you need to get some type of other avenue, because she says it absolutely kills her right now. She's been obviously doing it for 40 something years, delivered thousands and thousands of babies. And she says, I love it. But this is what I'm stuck on right now. She's like, I don't have flexibility to really go do anything else. So that's something that's kind of scared me a little bit. Yes, ma'am.
Well, please feel free to reach out if you have further questions. You're welcome to email me. I will put my email in the chat box.
Okay.
And I
Yes,
can
ma'am.
also connect you with, if you wanted to chat with anybody else about the F&P program, I can connect you with those people as well.
Okay, awesome. Thank you.
And
Thank you
you're
very much.
welcome, Adrian. Thanks for your participation in the chat.
Yeah, thanks. Well, thank you both. It was great to chat with all of you tonight. Anything else on anyone's mind?
All right. Thank you. Good night.
Thank y'all.
All right. Good night, everybody.